Good evening, all. I welcome you to the first lecture of 2026. And we are grateful to Dr. Balaguru sir for consenting to deliver a second lecture on the series that he had promised earlier. And for the new entrants, it's customary that we introduce our alumni of today. Dr. Duraisamy Balaguru sir is a pediatric cardiologist at Mass General Hospital for Children and assistant professor of pediatrics at Harvard Medical School. He was trained in his basic degree was from India, from Tanjore Medical College, one of our distinguished alumni. And the rest of his training was in the UK and the US. He's a board certified pediatric cardiologist and an adult congenital heart disease. He specializes in congenital heart disease and interventional cardiac catheterization with a strong focus on teaching and mentoring trainees. And sir has been so kind to give his time to all of us, and especially after the first brilliant lecture, which available on the TMC Medlock YouTube portal. Please go there and see that, where we discussed cyanotic congenital heart disease. And now we have another anticipating another great lecture from sir on acyanotic congenital heart disease. So the floor is yours.
Thank you very much, sir, for that great introduction. I have all this written here, but if I could, that's the simple introduction of myself. I'm an ordinary practicing physician in an extraordinary institution. So today we will look into acyanotic heart diseases in children and adults, brief epidemiology, and then look into pathophysiology, just how to understand, how to think through this congenital heart disease, acyanotic congenital heart diseases. Most of them are shunting lesions. And there is a concept of QPQS that is used very freely among the cardiologists, especially congenital cardiologists, but sometimes is somewhat non-understandable for non-cardiologists. So I thought I will just introduce that term QPQS. QP stands for pulmonary blood flow over QS, that stands for systemic blood flow, that is cardiac output. We'll look into it more as we go along. And then most of these are congenital heart diseases, and therefore the diagnosis starts at birth and then the presentation goes on. So understanding the perinatal circulatory changes that happen at birth and afterwards is important. So we'll touch upon that and then look into some of the clinical features and management of common congenital acyanotic heart diseases. I've listed a few there that are common. Among that, what is in yellow there, most probably we will just be able to cover those. And the other two, coarctation, touched upon it in the past when we talked about the pulse ox screening of the newborn. And then so they are all obstructive heart diseases: coarctation, aortic stenosis, pulmonary stenosis. So if there is time, we can do it, but I have a feeling we're just going to be looking at the others. So this is the epidemiology slide that I showed last time as well. Among all of the congenital heart diseases, there are several of them, but these 9 diseases constitute 81% of all congenital heart diseases. And the ones in orange are all acyanotic heart diseases. So if you take away the 2 cyanotic heart diseases in this list, you have 7 defects that will constitute 71% of all congenital heart diseases. So these are mostly left to right shunting lesions and obstructive lesions. These lesions are left to right shunting in the beginning, and then later on when pulmonary hypertension sets in, you would get the right to left shunting. That's when they are called Eisenmenger complexes. So we'll look into these shunt lesions today. So this is the concept of that QPQS. We use this a lot because it gives very quick way of conveying what the severity of a shunting lesion is. That's the amount of shunt is what matters. And that also changes throughout the lifetime of the patient. So here is a simple diagram of the heart. You can ignore all the little numbers that are printed on there, but just look at the larger numbers. There is number 10 everywhere. So starting with the arch or ascending aorta, there are 10. I tell this to the first year fellows. This is a lecture I give for first year cardiology fellows as they get in. We call it a boot camp for learning pathophysiology and cardiac catheterization, hemodynamic analysis, and simplifying the concept helps. So I would say, imagine that 10 RBCs constitute cardiac output. So somebody's cardiac output is 10 RBCs. So 10 RBCs are going out through the aorta into the systemic circulation, and 10 RBCs come back to the right atrium. So venous return is 10 RBCs. Let me get a marker. So 10 RBCs come into the right atrium, and then that 10 RBCs go to the right ventricle, that goes to the pulmonary artery. Pulmonary lungs are getting 10 RBCs. They come back to pulmonary veins, LV, aorta. So the circulation continues on. So here, the pulmonary blood flow, also called QP, is 10 RBCs. You can substitute that and then with 3 liters per minute per meter square as a normal value, but this is a simple way of thinking through this. And systemic flow, QS, that is cardiac output, is 10 RBCs. So if you do a ratio, QP over QS, what goes around comes around. So that's QP over QS is 1, and some people express it as a ratio. QP is to QS is 1 to 1. So it's very often people will see the congenital cases presented, and they will say the QPQS was 2, QPQS was 3, 4. That number comes out of cardiac catheterization using Fick principle. So this is the concept. And if you apply that to a left to right lesion, here a VSD is portrayed in the diagram. I'm going to, one more, yeah. So there is the, if we start analyzing this, it looks like a simple game, but it is very useful to understand this methodology, because in complex cases, very complex cases, when we do cardiac catheterization and making surgical decisions on these patients based on the cardiac cath data, understanding this principle is helpful. So we make the fellows do this exercise, very simple exercise in every case. So 10 RBCs is the venous return, and that goes to the RV. In the case of VSD, there is additional flow coming from the VSD, and that, let's say 10 more RBCs are coming from there. That becomes 20, and then that 20 reaches the pulmonary artery. And then there. Is it okay? And then 20 RBCs return to the left atrium, 20 RBCs come to the left ventricle. From there, 10 RBCs go back into the right ventricle through the VSD, and 10 RBCs go out as cardiac output. So if you take this equation, QP over QS makes it 2 to 1 shunt. What's the specialty of this shunt? For anyone to be symptomatic, they usually exceed 2 to 1 shunt. When a person has 2 to 1 shunt or above that, they tend to show these symptoms of the shunt, and the mitral valve flow murmur that we talk about, that will be present when the QPQS exceeds 2, and chambers show enlargement. So there's a correlation. For children, it is usually 2 to 1 shunt or above. For adults, 1.5 to 1 level itself, they start to show symptoms. So this is a useful concept. It is only available from cardiac cath. Most of the data are based on cardiac cath data that has been established for 30 years or so, or plus 30 plus years. And therefore, even though we are making decisions nowadays without cardiac cath, just with echocardiogram, the thought process in our heads is actually based on thinking through this QPQS concept. So a QPQS of 2 or more is going to be a symptomatic person. Coming back to this picture, one other thing to think about is when you're looking for which lesion causes which chamber enlargement is also something we can figure out using these numbers. Wherever you see a 20, that chamber is going to be enlarged. So in a VSD case, LV will be enlarged. It is a systolic shunt, and therefore RV doesn't get enlarged in the early days until pulmonary hypertension sets in. And then main pulmonary artery will be enlarged. All the blood vessels in the lungs will be engorged with blood. Therefore, they will look prominent in the chest X-ray, and left atrium will be enlarged. So wherever a 20 number is seen in this picture, those chambers are going to be enlarged. And this exercise can be done for any lesion. It's not just left to right lesion. It can be also used for right to left lesions too, and bidirectional shunting lesions also can be used. So in here, I've got the 3 common acyanotic heart diseases, VSD, ASD, and PDA. We just saw the VSD process, and if we apply it to the ASD process, the ASD is depicted in this diagram. There is the shunt coming in, venous return is 10 RBCs, and 10 RBCs, additional RBCs are coming through the ASD, and that makes it 20 in the right ventricle, 20 in the pulmonary artery, 20 in the lungs, 20 in the left atrium. And then there, 10 RBCs go back to the ASD, and 10 RBCs go through the mitral valve into the LV and cardiac arrest. And the PDA is a little different. So here you have venous return of 10, RV has 10, and 10 comes through the pulmonary valve, and PDA puts out another 10. So 20 happens to be in the main pulmonary artery, and that goes through the lungs, 20 in the lungs, 20 in the left atrium, and 20 in the left ventricle, and 20 in the ascending aorta. So ascending aorta will also be enlarged in PDA. And then after the aortic arch at the isthmus level, the PDA joins there, and therefore 10 RBCs just escape through the PDA back into the pulmonary artery circulation, and then 10 RBCs continue on as cardiac output. So all of these are QPQS of 2. And you can, in these diagrams also, you can figure out which chambers should be enlarged, which structures should be enlarged. We don't talk about aortic dilatation in PDA or main pulmonary artery dilatation in any of these left to right lesions, but main pulmonary artery will be dilated in all of these lesions. When you do echocardiogram or do a cross-sectional study, structural analysis of these lesions, you can see main pulmonary artery, and people don't talk about it because it's a understood part of the pathology. And all three of them are any left to right shunting. The common issue is increased pulmonary blood flow. All of them have increased pulmonary blood flow. That is what is going to cause symptoms. So we'll look into VSD as the first lesion to review this point. So VSDs account for 30% of all congenital heart diseases as an isolated lesion. But VSD can be part of multiple other complex disorders like coarctation, hydrology of flow, transposition of great arteries, various other conditions, truncus arteriosus. Back to this single, how the isolated VSDs, there are multiple terminologies used for types of VSD. It is, in frank terms, it's a mess because of different ways of calling the same VSD. So this may be one simple way of thinking through this. Just to know the 3 types. Within that, there are subdivisions. So biggest division thinking is membranous VSD, muscular VSD. And then add this special kind called the supracrystal VSD. And just here itself, there are so many controversies about which is called what, but it's better not to go into those controversies while we are still learning the VSTs. So here is a cartoon, very nice picture from the Yale website. So the right ventricular wall is taken away, front wall of the heart, and you are seeing the right ventricular side of the ventricular septum. All of the descriptions are made as though you are looking at this ventricular septum from the right ventricle, as you see in this picture. So the tricuspid valve has been removed, and you have this, and membranous VST is a small location. It's our membranous septum of the ventricular septum is a very small area in front of the tricuspid valve annulus, and it is below the aortic valve. So you can see the aortic valve through the VST picture here. And so this is the location of membranous ventricular septum. That septum in a normal heart extends a little bit above the tricuspid valve and then below the tricuspid valve. And the reason for calling some of it as perimembranous VST is the membranous septum is a very small structure in the whole expanse of ventricular septum. So if you have a VST that is larger than the size, potential size of a membranous part of the septum, then it has to be extending beyond its confines, and therefore it's better to call it perimembranous VST. It's just unnecessary confusion. So membranous VST and perimembranous VST mean the same VST. And so that's where we leave it. And the rest of the whole ventricular septum is muscular VST. So the whole part is muscular, and then how do you differentiate any of those things? So they are just then described based on some landmarks in the right ventricular wall. So first thing is inlet portion. Whatever will be covered by the tricuspid septal leaflet will be called the inlet VST. And then the rest of the major part is full of trabeculations. So that is called trabecular septum. And then the outlet portion is there below the pulmonary valve. That's the outlet portion or infundibular portion. So inlet VST, a trabecular VST, and then outlet VST. This supracrystal VST is a special kind that is right below the pulmonary valve. And in this VST is often small. It can be larger than small sometimes, but it is usually small. The importance of this supracrystal VST is that aortic valve is on the other side, and this is so high and very close to the aortic valve rim, and it takes away the support that the valve rim needs, and therefore aortic valve leaflets tend to prolapse through this VST, and often we close the VST that is not significantly large just to protect the aortic valve from getting destroyed. So this supracrystal type of VST is very common in Far Eastern population, and it's not so common in the Western population. We see a small number, but it's very common in the Far East, Japanese. Some people actually call it Japanese type VST, but referring to any location is banned nowadays, so we just call it supracrystal VST. So these are the three types of VST, and within the muscular type, we have the apical VST, anterior VST, mid-muscular VST. All of these are just descriptions that we come up with under the muscular VST category. That's just so why is it called supracrystal? One of the trabeculations in the right ventricle is called crista supraventricularis, because that big septomarginal band is the other name for that trabeculation, and that ends up with a Y on the top. And that Y portion is called crista supraventricularis, and this portion is the one part of the Y, and that is, this VST is above that crista, and therefore it's called crista supraventricular, supracrystal VST. And this is also called doubly committed subarterial VST, multiple names. So we are back to this concept 2 to 1. What are the next step in this is how does the symptoms start in left to right lesions? Increased pulmonary blood flow is the common mechanism in all of these, ASD, VSD, and PDA. And the increased pulmonary blood flow causes stiffness of the lungs, otherwise called the decrease in the lung compliance. Therefore, there has to be increased work of breathing for normal breathing. This induces signs of respiratory distress in an infant. So what are those? Increased work of breathing, so accessory muscles are working, tachypnea, and chest retraction. So these are the signs of these lesions. And this difficulty in breathing in an infant leads to difficulty in feeding because babies have to stop the breath to take the bottle. And they very readily choose the right thing to continue breathing if they don't feed. So decreased food intake leads to poor gain. So that's the sequence. Respiratory difficulty, feeding difficulty, poor weight gain. And there is heart failure in the background, and that requires higher caloric intake. And so difficulty in feeding happens in the presence of increased need. So both together lead to failure to thrive. And what's the timeline for appearance of these symptoms? For this, we need to understand advancing. Okay. We need to understand the perinatal transition in the circulation. So from the fetal circulation to postnatal circulation, several things happen. Obviously, most of them are obvious, but they have implications on the shunting lesions. First thing is the lung expands. So as soon as the lung expands, the pulmonary vascular resistance starts to drop. It drops precipitously at birth when the first breath is taken, and then the drop is much more gradual. And then placenta is removed from the circulation. Placenta is a low resistance circulation. So removal of the placenta increases the systemic vascular resistance. So those two things happen. Pulmonary vascular resistance drops, systemic vascular resistance increases. And then two channels close. One is the PDA outside the heart and PFO inside the heart. These two channels close. And then fifth thing that happens, that's the gradual change, is pulmonary artery vessel wall undergoes remodeling, which includes thinning of the medial layer of the pulmonary artery wall, and that slowly decreases the pulmonary vascular resistance. So that is another, the time course of this remodeling is something that is going to be crucial when the symptoms of left-right lesions is going to show up. So here is a pictorial representation of this. So pulmonary vascular resistance in this second panel and pulmonary blood flow in the third panel. And we can just look at the VSD example. That's a dotted line on the top. So in the x-axis, birth is 0. Then there is half a year, so 6 months point. So here is your birth to 6-month mark, and the pulmonary vascular resistance drops gradually. And it reaches its lowest point somewhere in the region of 3 to 4 or 3 to 6 months. And that's the time the pulmonary blood flow is going to reach its maximum potential. So you can have a large VSD, but the flow through the large VSD may not start until some time, and then symptoms may not start for 6 weeks or 4 weeks. That's because the flow is still increasing and the QPQS has not reached its full potential. And by the time 3 months, 2 months rolls out, usually you see close to the maximum level of flow going through the VSD. So that's the time there you see the maximum symptoms of this. That time frame is helpful to know. So here is a case to think through this. 36 weeks preterm, born at body weight of 2.2 kilograms, discharged home on day 2. There was day 5, jaundice was noted by the primary care physician. The second 2 days later was checked again and it was further increased. And therefore, baby was admitted for phototherapy. The baby started to show poor feeding 2 days later, and then the heart murmur was noted at day 11 examination. And from outside hospital, patient was transferred to this hospital. There is a family history of ASD in the elder sibling. And our examination at this point, day 11, baby has warm extremities, good peripheral pulses, normal femoral pulse, no dysmorphic features, coarse cry, chest retractions, and respiratory rate of 76, and four-limb blood pressure not too significant. If you take these two numbers, it looks significant, but good femoral pulse, and therefore coagulation is less likely, and the saturation is normal. Patient is acyanotic. And cardiovascular examination increased precardial activity, and murmur that is grade 2/6, relatively low frequency. This is happening because the pressure difference, the right side pressure is still on the relatively high side, but the flow into the pulmonary circulation is already increased enough to cause symptoms. And pansystolic murmur in the left mid-sternal border, subcostal retractions, liver 3 centimeters, chest X-ray. This is that baby's chest X-ray. Mild cardiomegaly and slight increase in pulmonary vascular markings, nothing significant. And the echo showed 9 millimeter midmuscular VSD. So that is a large VSD for a baby who's 2.2 kilograms. But the flow hasn't reached its full potential yet. And the murmur is also not sounding very significant at this point. That is also because of VSD being large and the RV pressure is still staying high because of pulmonary vascular resistance still remaining high. So high calorie diet was started, initially at 20 calories per ounce, and then we gradually increase it to higher calories per ounce, as much as 30 calories per ounce. Lasix, digoxin, and captopril were gradually started. And this is the baby's daily weight chart. Baby stayed in the hospital for a long time because of other reasons, not just for cardiac reasons. During that time, this is basically a daily weight chart. And if we keep seeing, we were able to get the baby to grow with medical management. And it's at around 60 days or so, baby stopped growing. So here is your flat line. So these days we're looking into what's going on, and but manipulated some of the medications, NG tube feeds, but no growth could be demonstrated. So this is the level of failure of medical management, and baby went for surgery on day 8. This is the change in the chest X-ray for this patient from day 11 to day 60. Slightly increased pulmonary vascular markings, but there now it is grossly increased. There is more congestion added to that increased vascular markings, and the cardiac size has become larger. So it's the same VSD, but the pulmonary vascular resistance has dropped further, and therefore the flow has increased. And we are now seeing the full flow through the VSD. And the child had surgical closure of this VSD. I just put a picture for this. It's a patch closure. And there are now efforts to close these without surgery. And this child had surgical closure. The other options are transcatheter closure. Transcatheter closure is relatively easier for an older child, but most of the VSD children who need surgery need it within the first year of life more often than not. And therefore, we really needed some solution for transcatheter or non-surgical closure of these VSDs in the infants. And also, some of these VSDs can be inaccessible for the surgeon in the operating room. Nowadays, we try not to do ventriculotomy to close the VSDs. The surgery is done through the right atrial incision, through the tricuspid valve. Surgeons close these VSDs. So if we can avoid ventriculotomy, that's very well shown that that's much better for the long term. And so almost never do the surgeons do ventriculotomy for VSD closure, except in tetralogy fellow patients. But when the VSD is closer to the apex, it's very hard for them to look through the trabeculations on the right side and also to place sutures. The trabeculations are in the way. And sometimes it's even hard to figure out which is interval between trabeculations and which is VSD. And therefore, catheter-based treatments have become attractive. So we've been able to close these VSDs using the muscular VSDs. The membranous VSD is in a place where multiple valves are nearby. The aortic valve is on the left side and tricuspid valve is on the right side. Placing any device in the membranous VSD is hard. Similarly, the supracrystal VSD also cannot be closed in the cath lab, but the midmuscular VSDs, apical VSDs, can be attempted in the cath lab. So this is one of these cases, midmuscular VSD that's been closed through a jugular venous access. And this shadow is the transesophageal echo that is used as a guidance. This is the VSD device. It's a modification of the ASD device and accounts for the thicker ventricular septum. And this finished position of that VSD angiogram. So apical VSDs are almost always difficult for the surgeon to reach, especially in an infant. So with all of these difficulties during surgery and also during cath, reaching the apical VSD is harder for the catheterizer as well. There have been instances of having multiple near-miss, near-death events. Pericardial effusion, perforation of the heart with the catheters have happened in this situation. So a safer way to approach this can be a hybrid procedure. So here is a setup. This is just hybrid procedures can be done with no special equipment either in the cath lab or in the operating room. This one needs sternotomy, and therefore this is done in the operating room. Surgeon is here, 2 surgeons, and the interventionalist, my colleague, is preparing for this case. And this looks like me, but it is not me. So a friend of another colleague of mine, Chandramoulishwaran, is this person here helping with the transesophageal echo guidance. And here is the procedure for hybrid VSD closure in the apex in an infant. This sternotomy is made, and you feel for the throat. So you have to insert the catheter delivery system. And so you have to figure out where to go in. And so that is decided on by feeling for the throat. The surgeon is feeling it here and select the access location. And then this is just a simple Seldinger technique like we would do for the skin to enter the femoral vein or the other central venous catheterization. So there is the needle. Through that, the wire is placed, and the needle is taken out. This is the Seldinger technique, and there's the wire. Now, here is the sheath being inserted over the wire, and there is a purse string suture around the right ventricular wall, and we are going directly through there. And here is the insertion. These sheets are very big for the child's heart, so it has to be very carefully advanced. Even the sheath, the dilator is working so much beyond its borders. And here is the sheath after the dilator has been removed. That's the delivery sheath across the VSD. This is the ventricular septum here. We've already gone through the VSD. And this final result, the device was delivered through that setup. And the procedure is a successful procedure at that point. So this is the final picture. So this kind of hybrid procedures make this process simpler and reduces the complications both from surgery and from cardiac cath. I've personally had a death on the table from perforation of the left ventricular apex. And so those are situations where you hesitate to take the patient to the cath lab, and the surgeon who has failed closing the apical VSDs adequately in the past, so they are hesitant too. So hybrid procedures are the solution for that kind of situation. Overall, for the natural history of VSD, small VSDs, they all close with time. And 30 to 40% of them close in the first 6 months. Most of the ones that are going to close by 4 years. Beyond that, whatever you see probably is going to remain in certain level throughout their lifetime. They can still close theoretically. Large VSDs, pulmonary hypertension sets in 6 to 12 months, and that becomes irreversible in their teenage years. That's when the Eisenmenger syndrome risk happens. And infective endocarditis happens, relatively rare, but it happens. And then there are these structural issues that can happen with an asymptomatic VSD during our long-term follow-up. These three are the reasons to follow these VSDs, even when the patient is asymptomatic and these VSDs become relatively or hemodynamically insignificant. One, RV muscle bundle can develop in the right ventricular side and create subpulmonary stenosis. I'll show you one example of each. And then subaortic membrane can develop next to the ventricular septal defect and cause subaortic stenosis over time. This develops over 5 years, 6 years, 10 years. And then aortic regurgitation, already we mentioned that in the supracrystal VSDs, the aortic valve prolapses through the VSD and causes aortic regurgitation. And the aortic valve leaflet gets destroyed. And that's when we do the surgery before anything progresses to that level and causes lifelong problems. So here is the RV muscle bundle story. There is a small VSD, LV is on the side, or RV is in the front. This is the subcostal sagittal plane. And you have the pulmonary valve higher up here. This is the infundibulum of the RV. And this muscle bundle has developed in the past year or so. And you have this flow pattern showing there. So this is subpulmonary stenosis developing, not present at birth, and then slowly develops over the first 2 years. And the VSD is not very big. It's become very small. So patient is not symptomatic from the VSD. So this is the second thing, subaortic membrane. So 4-chamber view, LV, RV, ventricular septum. You see the flow through the membranous ventricular septal defect. And then aorta is in the top, just part of it is seen. Aortic valve is here, and the membranous septum is developing on that edge. So this is a fibromuscular membrane that creates subaortic stenosis over the years. And the time frame for this to develop is 5 to 7 years, and that will need surgery. And this also has potential to destroy the aortic valve leaflets because of the eccentricity of these shunt flow coming out of the LV just hits the valve in a different way, and that starts to destroy the valve. And then the third problem that can happen is here the prolapse of the right coronary cusp through the VSD. Here is that, I'm going to stop it at some point just to see. So what is here on the RV side of the ventricular septum is cusp, one of the leaflets of the aortic valve. And the effective VSD is quite small. When you see the color, it's really small. But that's not a significant shunt, but this valve will progressively get worse, and aortic regurg will start. I think I have a aortic regurgitation showing in this plane. In this plane, we don't see any aortic regurgitation. Here, the blue jet here is the aortic regurgitation. When we start to see this during follow-up in the VSD, usually they are 5, 6, 7, or 10 years old by this time. And it's very hard for the families to accept that that child needs surgery to prevent future aortic valve damage. So those are three reasons why long-term follow-up of asymptomatic VSD patients. All three of these are happening in membranous VSDs. Muscular VSDs, they don't have this consequence. So membranous VSDs need to be followed even when they are not significant. This is the weather we are dealing with currently. This is a picture from yesterday. It's our house. It's outside our house. This is what is happening. We had 2 feet of snow last weekend. In spite of sun shining every day, this snow is not melting because we have a long spell of below 0-degree temperatures going for the past 2 weeks. So this snow is not relenting. So a picture like this means that you're moving into a different topic. You see some messages in the Some people have said it's not audible. Is there anything I could do, I wonder? I will go closer to the computer and see. Okay, so next topic is the atrial septal defect. There is this cartoon similar to the picture that we saw earlier. Atrial septal defects account for about 10% of all congenital heart diseases, more common in female. And there are different kinds. I think to simplify the whole classification, we can just think about them as 3 of them. Secundum ASD, which is in the middle of the septum. Primum ASD is in the bottom of the septum, and the AV valve will form one border of the atrial septal defect itself. And then the superior sinus venosus ASD, which is rare. And there are 2 kinds, superior sinus venous ASD and inferior sinus venous ASD. That's a simpler way to think about it. This inferior sinus venous ASD is a controversial terminology, but we will stay away from controversy. But these 3 ASDs are important to know. And while we are talking about transcatheter non-surgical closure of this, only secundum ASD can be closed in the cath lab. There are people who put a covered stent to deal with this superior sinus venosus ASD. Actually, the person who's world expert on this is Dr. Sivakumar in Madras Medical Mission. He has a collaboration with Guy's Hospital in London, and he is doing a lot of cases where this superior sinus venous type ASD is tackled in the cath lab, but that's not widespread practice. So this will be considered surgical case in many centers, including ours. And we'll come back to that in a minute. And then the primum ASD is actually part of endocardial cushion defect that we see in Down syndrome, but it can be seen in non-Down syndrome patients as well. So this is, again, the exercise that we did before with the 10 RBC cardiac output. And all these 20s are representing the chambers that have been enlarged. So left atrium, right ventricle, pulmonary artery, and increased pulmonary blood flow will be the combination of features. And the presentation will be respiratory distress, poor feeding, poor weight gain, our precordial bulge indicating right ventricular enlargement. And the hallmark of ASD in auscultation is the fixed white split of the second segment. And then a functional flow murmur in the pulmonary area, because that is the next narrowest point this additional flow is coming across. So once you have 20 RBCs here, that's twice the volume of normal. The tricuspid valve is a very large valve, and therefore it takes a lot for that to be overwhelmed. But the pulmonary valve is relatively smaller. Therefore, increased flow through a normal pulmonary valve creates that pulmonary stenosis type of murmur, which is a flow murmur. That's the murmur of ASD. The murmur, there is no murmur generated at the hole. And then you have the chest X-ray showing RV enlargement, dilated pulmonary arteries, right axis deviation, and right atrial right ventricular enlargement. And you can have biventricular enlargement seen in the EKG as well. So those are shown here. There is a prominent main pulmonary artery segment, so pulmonary artery enlargement. RV enlargement is not that obvious, but you can see it. The apex is a bit lifted, so that will go for RV enlargement. And you have mildly increased pulmonary vascular margins. And the EKG has RSR prime pattern with the R prime exceeding 10 in V1. So that's one of those important characteristics. And we have a right atrial enlargement here. And some people report crochetage. This will be called the crochetage. In inferior leads, 2-3 AVF can have that. That is taken as a sign of ASD, but no one knows the mechanism, how it is created, but it is not uniformly seen. And you see this in normal patients too, normal people too. Therefore, this is not a very good sign in EKG to diagnose ASD. So here is a picture of secondum type ASD. It will be in the central part. So you have a certain length of septum separating it from the mitral valve and the tricuspid valve, and certain amount of septum from the roof or the back wall of the atrium. That's the secondum ASD. That is a typical ASD that we can. That's the typical ASD that we can close in the cath lab, like this picture is showing. If it is very large and unsuitable for transcatheter closure, surgical closure using a patch is done. If it is relatively small, then the surgeon can do primary suturing of the atrial septum. But often, if you pull together large ASDs, there is distortion of the AV valves and other tissue, and therefore, so even AV nodal tissue can be affected in this. So try not to do that unnecessarily. Do a patch. Autologous pericardial patch or Gore-Tex patch will be used. So and here is the just small demonstration of the atrial septal defect closure in the cath lab. There are multiple devices available, but the principle is the same. The device collapses itself and it is pushed through this catheter, and the catheter is placed across the ASD, and you push out one half of the device. That would be the one disc, and then pull it across against the atrial septum, and the waste of the device is delivered in the septal area, atrial septal defect, and then you release the right atrial disc on the side. I will show a video of this. That device is shown, and when you pull the device apart, you see the waste, and the waste pulls it in the ASD. There is a short video that goes about 1 minute or so. We have the ASD here, this transesophageal view, and this is the catheter view. We have the catheter has gone across the ASD into the pulmonary vein, and that's the ASD here. And you size the ASD using a balloon and choose the device based on that balloon size. And the device is chosen and it is being loaded. Screwed onto the delivery cable, and this will be pulled into a loader. Here is the loader coming up. Underwater will be loaded. Still wide bubbles. We're better off doing it slower than what is shown in the video. And here the loader is used to transfer that device from the loader into that long sheath that's already placed across the ASD with the tip in the left atrium. It's advanced. And this is the left atrial disc coming out on the left atrial side of the atrial septum. And you have the transesophageal echo guiding you, and then the right atrial disc. Or I can describe it. This person is fast. This is Dr. Hijazi. This was recorded in Tufts Medical Center where I used to work before. And this is the final result of it. The device is in the atrial septum. And there are other designs, but basic principle is the same. This is called the helix device, originally called the helix device because of its appearance. And this whole left side collapses into a disc, and then the right side collapses into a disc. You finally have that final appearance on X-ray. And then endothelialization happens over the next 3 to 6 months. There is endothelialized view of it, left atrial side, right atrial side. So this takes about 3 months. Therefore, all these patients go on aspirin to prevent any clot formation on the device for a 6-month period. Once endothelialization is complete, don't. And also, what about these little spaces showing up? This also, under microscope, all of these have some cells covering them, actually. And therefore, they don't gather clot after the 6-week mark. And that's the ASD, and they are usually symptom-free for the first 20 years of life. In 20 to 40, they start to have some exercise intolerance. And then over 40 years of age, the LV compliance decreases. This increases the left atrial pressure a little bit, and that pushes the ASD shunt more and causes atrial. And then long-term, the enlarged atria going to atrial arrhythmias, pulmonary hypertension, heart failure. And patients with ASD seem to have a higher incidence of systemic hypertension. We don't know the reasons. And then there is always a discussion, say 50-year-old, apparently asymptomatic person has an ASD that's significant. And then this person has made it to 50 or 60 years of age. Should that person actually need closure of this ASD? That's a common question that comes in, even 60-year-old. And some of them are athletes. Some of them are still running marathons. So certainly the answer to that is yes, they still need it. This is the follow-up study, came out in New England Journal in 1995. Follow-up was 1 to 26 years, mean follow-up of 8.9 years, 79 patients. In that follow-up period, people who had surgical closure of the ASD had a higher survival compared to the medical group. Medical group is patients who did not get surgery for whatever reason, patient choice, doctor's choice, or whatever reason. So they are not randomized patients. This is just a retrospective study, but better survival in the surgical group. And then what are the problems they ended up with? Pulmonary hypertension, atrial arrhythmias, paradoxical embolism. And one important point about atrial arrhythmias is when you are closing the ASD as an adult, you may not be preventing the risk of atrial arrhythmias. The risk of atrial arrhythmias still remains in those adults, in spite of closing the ASD in their 40s and 50s. If you want to avoid atrial arrhythmias as a result of ASDs, the ASD needs to be closed before 10 years of age, and there is some evidence to say before 20. If you're closing it after 10 years, there is some incidence of atrial arrhythmias later. And then this is another one. This is survival. And another study this is at presentation at the top, the symptoms. There are more patients who are, during follow-up, developed class 3 and class 4 symptoms that they didn't have before. So people will become symptomatic in the 8 to 9 years follow-up. So that's about ASD. I think we are running short of time even for PDA here. So let's see. This is also taken yesterday, our medical school. Look at these leaves with trees with no leaves. This is actually the appearance last summer, and this is the usual annual cycle of weather and climate in Boston area. So I think we are already out of time. Maybe we'll stop here and think about PDA at a later time. These are endocardial cushion defect cases. And now let me just talk about this. This is three slides on this one. 3% of all congenital heart disease. This is a typical lesion in Down syndrome patients. And it's also called AV canal or endocardial cushion defect. And currently, people like this word, atrioventricular septal defect. It is not very representative. None of them are satisfactory. Still, AV canal is a very popular name. Can be partial or complete. In the complete form, you have ASD, VSD, and a common AV valve that spans right side and the left side with 5 leaflets, tricuspid and mitral, put together. And this is one of those patients. You have a secondum ASD, you have a first primum ASD, common AV valve, and a small VSD in this situation. Often the VSD is large as well. That's typical in the case. It sounds like, oh, it's a ASD and a VSD and a common, but it's a major defect that the surgeons take it in their stride, and you've learned how to repair these valves and make them into 2 valves of that. And they are usually operated between 3 and 6 months of age with various techniques, depending upon how big the ASD is, how big the VSD is, what the nature of the AV valves are. Single patch technique, 2-patch technique, or a modified single patch technique. Modified single patch is on the atrial side, and you push down, and you have a small VSD. You can just push down from the atrial side and tack it all to the ventricular septum below. So Down syndrome patients have this as a typical lesion, but commonest lesion in Down syndrome is actually VSD. And that's our backyard as it is right now. From last, there's 2 feet of snow there. I think I will stop here and we can have some discussions and go from there. Thank you very much.
Non-cardiologist, but kind of revisit to the septal defects has been very interesting. And I hope it was very interesting to the students as well. So thank you for your time and great expertise. Now the floor is open for questions. There are a few questions in the chat box, sir. Can you see them?
Okay, let me see.
There are a few questions in the chat box, sir. Can you see them?
Okay, let me look at it. Okay, so let me start from the first. Okay, so Dr. Neelakantan is asking, so kindly let me know the echocardiographic findings for the restrictive type of VSD. Yeah, so restrictive is basically a small VSD. So we will try to line up the Doppler probe to the jet of the VSD and estimate the pressure gradient across, and that will usually be more than 40-50 millimeters of mercury. That will be the pressure restriction. There is a terminology or statement said all pressure restrictive VSDs need not be volume restrictive. So we have to be careful about what restriction we are talking about. So pressure restrictive VSD also, that will cause the highest pitch of the murmur. And people generally say, oh, the loudest murmur is coming from the smallest holes. That's true in the VSD situation. That's about the pressure restriction. That usually translates into volume restriction as well. But the volume restriction should be assessed by the structure of the chambers. RV should be normal size, main pulmonary artery should be normal size. You do a X-ray, should not see significantly increased pulmonary vascular markings. So that will also go with patient doing well without any symptoms. So that's how. So it's a combination of the echo finding with the clinical features. And then for the size edge to edge and breadth of the color, yeah, that is so the color overestimates the size of the VSD. So let me read the question again. Do you measure the size of the defect as edge to edge of the defect or breadth of the color jet across the defect in the echocardiogram? So 2-dimensional measurement is the correct way to measure it because the color will overestimate the size of the VSD. Color bleeds beyond its borders. That's basically the statement. But there are situations where you see the color jet coming out nicely, and you take away the color to measure the VSD, and you don't get the edges clean. So it's harder to measure. So a practical aspect is I measure both, and I take the in-between number as a actual number. Say, for example, if you have a 2 millimeter diameter by 2D measurement, the black and white measurement, edge to edge, then you put the color, you will have 3 or 3.5 millimeters in there. So the truth is somewhere between 2 and 3.5. So it's okay. So there is a device embolism question. So what's the incidence of possibility of a device embolism? What do you do? So, and then, so let me answer that one, and then we'll go to Murugesan's question on the transcatheter closure. So for the device embolization, for VSDs, it's not done that commonly, and therefore it's difficult to give a number. The ASD part, we have learned a lot from the days of starting to do the ASDs. ASD device was approved in 2001 in the US, so 24 years of post-approval. I started doing them in 1996 as part of the trial, 1999 as part of the trial. The initial device embolization rate for ASD was 6%. But of late, we don't see almost any embolizations, but you can never say never in medicine. So it should be 1% or less for the ASD devices. For the VSD devices, again, membranous VSD is also being closed. I think in India, there is a lot of membranous VSD closures. In the US also, membranous VSD gets closed in the cath lab. It has to be of specific kind anatomically. Not all membranous VSDs can be closed. I think, and it is not uniform. In the practice, it is not uniform. In the US, the majority of the centers do not close membranous VSD in the cath lab. For muscular VSD, the embolization rate is very small. Very small is 4%, 3%, because you know it, you are delivering it, if it is stable or not, the VSD situation. And then the PDA device closures, we didn't talk about PDAs, but PDA device also has a certain level of embolization. That also not a straightforward answer. We had about 3-4% of PDA device embolization in the early days when we had only Gianturco coils or Amplatzer ductal occluder. These were the only two devices available for a long time. And then now multiple different devices have come out, and each one of them have a different design characteristics that we are not using them. Or when we are not happy with something, we actually go to a different shape. And therefore, we are having this less of a problem. And transcatheter closure of sinus venosus type ASD, Dr. Murugesan has asked for about. So sinus venosus ASDs are associated with partial anomalous pulmonary venous return. The anomalous pulmonary vein will be from the right upper lobe of the lung. Sometimes middle lobe also will come in, and that will come into the SVC. Often it comes close to the heart at the SVC-RA junction. And people have shown by MRI and CT scan studies that if you put a covered stent going from some level of the SVC, usually below the junction with the azygous vein, and then make that covered stent hang inside the right atrium, you are going to close the ASD towards the left atrium, and the pulmonary veins find a pathway around the junction into the left atrium. So that is the technique that's being used for closing the sinus venosus type ASD. It's a covered stent placed starting from some distance in the SVC and coming into the right atrium. So that's, you have to think of it, imagine a lot to think how this might work. But in our center, we will just go for surgical closure and reimplantation of the pulmonary veins necessary. Oh, another situation is the pulmonary veins are coming up way high in the SVC, halfway point of SVC. Then the stenting technique will not work. That patient has to go for surgery, closure of the ASD, and reimplantation of that right pulmonary vein. Okay, I think that's all the questions are.
I think the questions or comments, please feel free to unmute yourself and ask the questions.
Balaguru, what is the mechanism why people with a small VSD develop subbiotic membrane?
Oh, yeah, we don't know the mechanism. Yeah, why that membrane starts. Yeah, it's a fibromuscular membrane. People have studied them under microscope to see what it is constituted of. It's fibrous tissue or fibromuscular tissue, a little bit of myocardium in it. And also that's one part of it. The other part is even after surgically removing it, it recurs. It can recur 5 years down the road. So when we send a child for this kind of surgery for removal of that subbiotic membrane, we want the families. This may not be the only time this person needs surgery. There may be another surgery coming down. So we don't know. So.
Excellent, sir. I think if there are no further questions or comments, we can call it today. And sincerely, thank you for giving us another lecture. This particular lecture was definitely different from the earlier one. And, but in terms of the scope and the vastness of the topic, and you have done a great justice, especially the pearls of wisdom shown through. And definitely we have a lot of points, key points. For exam going students, there are a lot of points which can be picked up. Conceptually, it has clarified quite a lot of common things. I think these are common examination problems for the MD, ASD, and VSD. So thank you so much for your time. Thank you so much for your expertise. And hopefully we'll have time for talking about the PDA. Thank you, sir. Thank you, everyone, for attending the first lecture of 2026. And we'll be lining up a series of lectures coming up for the next weekend and the weekend after. So I'll post the links as usual, and I will post the recording as usual. Thank you for your kind attendance. And with that, we'll call this meeting to an end.
Hello, everybody.
Thank you.
Hello, Venkatesh.
Chalunga, sir.
I suggest all the members to share your invite to other groups also, IME groups.
Sure, sir. I'm doing that, and there are a few people on and off they join actually.
So that more members will join the lectures.
Yes, sir. Yes, sir.
Yeah.
Sure.
IME functioning?
Yes, sir.
Okay.
Thank you so much, sir. Thank you.
Thank you, Balaguru. God bless you.
Thank you. Thank you, sir. Thank you, Captain, sir.